In the interest of time, then, I will just pass straight over to Dr. Hamid Kazerouni, who's Associate Professor of McMaster University, trained in Oxford in the UK, is an expert in gynecological pathology, and is going to talk about endometrial adenocarcinoma. I will mute, and I'll probably actually leave the room for another appointment I have to have just now, but I will come back shortly into the session. Thank you very much for your attention, and so without further ado, thank you, Hamid. Thank you, Charlie. Over to you, Hamid. Thank you.
Okay, thanks, Richard, and thanks, Charlie. Good afternoon, good morning, and perhaps good evening to people around the world. And sorry for last week, we couldn't go through. There was some technical issue, but hopefully today we can just go through the case. So I would, as probably most of you knows, the WHO classification 2000, Blue Books 2026 is supposed to come, relatively soon, hopefully next couple of months. But I'm just going through some, revision of what it is in 2020, which is almost the same as what we're going to get in 2026. Not much change from the purposes what we are going to talk about. And then I would like to just, talk about the criteria on slide morphology, what we use for the adenocarcinoma in situ, for the resident mostly, and then, talk about the classification of Silva classification or pattern-based classification, which I believe most of you probably are using it and your clinician are aware and everyone is on the same page. So let's just start with the first slide. It's in fact in 2018 group, a International Endocervical Adenocarcinoma Criterion Classification, IECC, has been published, and what they did in their study, they look at so many cases and they were just looking to see if they can classify this adenocarcinoma based on the pathogenic or what is the cause for this tumor. And again, I'm not going to talk about squamous at all, it's just adenocarcinoma. And so in 2018 they published their finding, and in 2020 WHO in fact adopted that classification. And I'm just looking at showing you the 2014, which we were just based on morphology classifying this adenocarcinoma of the cervix. Whereas on the right side, you can see 2020 WHO book classified these based on the pathogenic cause, and that is HPV-associated cervical adenocarcinoma or cervical adenocarcinoma independent of HPV. And within the group, which is the majority are HPV-associated, majority of those are the usual type, which I'm going to show you some of the slide morphology. And there was, about 10% of the cases of cervical adenocarcinoma are mucinous type, which there are different subtypes, which I'm going to go through some of those. And then eventually we're going to talk about the HPV independent and the cervical adenocarcinoma. So as you know, there is, adenocarcinoma in situ. Again, those are classified based on, are they associated with HPV or they are independent? And the majority usual type, and some of them like, SMILE, I'm sure some of you have seen those and you have made the diagnosis. And then HPV independent, which some of them are in fact, very new relatively. So the recommendation for diagnosing the usual type or HPV-associated adenocarcinoma in situ for resident, when you have a cervical, tissue, either biopsy or a lip or cone biopsy, what you have to do is just under low magnification, scanning magnification. If you see there is definitely, blue, and those glands, they have apical mitosis, and you have the apoptotic body, then almost you are certain you are dealing with a HPV-associated carcinoma, either in situ or adenocarcinoma invasive, which we're going to talk about. And if you're really struggling to find any of these, mitosis, apical, or any apoptosis, maybe you are dealing with a HPV independent. So for resident, again, I remember when I was resident, not, almost long time ago. So always the consultant, I was trained in UK, and they were saying, learn your histology. And, sometimes you really don't appreciate what they are talking about till later on when you are practicing. So the reason is, if you know your histology, normal histology, as soon as you put the slide under your microscope, there is something doesn't look right. The morphology, the pattern is not correct or whatever. So when you look at here, and what I'm trying to show you is the thickness of the normal cervical mucosa, a glandular component, and the distribution of these glands and density of these glands. You go to higher magnification. This is a normal glandular glandular component of the cervix, which you can see. There are tall columnar epithelium with a basally located small nuclei, and there is no mitosis, there is no any apoptosis. So when you look at this one, then you think, okay, this is normal cervical glands. So when you go to the next slide, what you see here, as soon as you put the slide on the microscope, and you can see this is not a normal, what you were expecting as a normal histology. So you see it's definitely blue. The glandular component seems it's hyperchromatic nuclei, pseudostratified, which I'm going to show you in a higher magnification as well. But the most important here, you have some abnormality, and most likely this is, a glandular carcinoma, either in situ or invasive malignancy, and you want to confirm it, okay? When you go to higher power, and you can see there are some normal glands adjacent to the abnormal glands, or there is an abrupt transition from normal to abnormal. When you look at the higher magnification, you can see this glandular epithelium has got a dark nuclei, pseudostratified, some apical mitosis and apoptosis. Here, the picture shows very well that what you can see, lots of apoptotic bodies. You can see there is pseudostratification of these hyperchromatic, very dark nuclei, and you have apical mitosis. Especially these can be slightly more difficult when you look at on the microscope during a frozen section, which because of artifact can be slightly hard. And you have to pay attention for the pitfall. So another slide, I'm sure you recognize this is not normal, this is abnormal. So again, glandular component, abnormal, looks, at least adenocarcinoma, could be either a invasive or non-invasive. So the question is, when you have this complexity of the glands, you have cribriforming, you have some intraglandular proliferation, are you still within the category of adenocarcinoma in situ or invasion? What about this one? You have a normal gland at the periphery, and then you have some abnormal gland with cribriforming. And I remember some of my colleagues, or when I was resident, you were just struggling. Is it really invasive, or is it still, adenocarcinoma in situ? And sometimes you get these intestinal metaplasia, especially in cytology, can be very tricky, and you don't want to miss those. I don't know what's happened. It's just go too fast. Okay. The next one is, one of those adenocarcinoma in situ, SMILE one, which is, we call it stratified mucin-producing, lesion, which can be slightly, tricky for resident if you haven't seen it before. And you look at it, there is some abnormality, but you don't know, is it really squamous epithelial lesion or is it really glandular? What you have here, you have a stratified epithelium for sure. And the full thickness has, when you look at in individual cells, you have intracytoplasmic mucin, the nuclei are abnormal, hyperchromatic, and you have mitosis along, the full thickness. So when you have this kind of cases, you know you are dealing with a SMILE, which is a kind of adenocarcinoma in situ, not invasive. So what about here? We talk about the glands with pseudostratified, and you have hyperchromatic nuclei. When you look at this slide, especially on frozen section, you may think, okay, we have adenocarcinoma, full stop. Whereas just be careful, this is a endometriosis, not adenocarcinoma. Why? Because, as you can see here, you don't have any apical mitosis, you don't have any apoptosis, and if you are concerned, you can do P16, and it should be really patchy, not full thickness blood P16 positive. What about this one? And again, as I said, these are sometimes on the frozen section can be slightly tricky. And here, again, if you have, if you want to know history of this patient, in fact, this patient had a previous procedure, and this is in fact a tubular metaplasia. And again, it can be a little bit tricky because when you look at it, it looks very blue, looks, hyperchromatic, but you have to be careful about these pitfalls. And if you do a P16 on the left-hand side, you can see it's just patchy, meaning it's not really a high-risk HPV. And the right side, some of the glands are blood positive and some are not, which those are blood positive, they're HPV associated. And this is just as another slide of, this is someone who is in fact, it's more associated with the pregnancy or progesterone effect. This is ariostylate effect, which you have to be careful not to overcall this as adenocarcinoma in situ, again, for resident. So by now, I'm sure, and you knew this one, and when you look at it on the microscope, this is not normal. This is surely abnormal. This is glands. What you want to go, the way I approach the case is, okay, I know this is glandular process, in fact, is going on, and this is at least adenocarcinoma in situ. But when do I say this is invasive, in fact? So I told you, when you look at the normal histology, you look at, how deep the glands are going. Is these glands are going too deep? I remember when I was resident, how deep is really too deep for considering this is a carcinoma? And no one really has defined it well, in fact. What about this one? I remember, again, intraglandular complexity. Some consultant would consider this one as, being probably more than adenocarcinoma in situ. What about this one? You have some debris in the glandular component, is very cribriform, again, intraglandular proliferation. So what is the management of invasive adenocarcinoma? We know that is really based on recent FIGO or HACC staging system, which is based on tumor size and depth of invasion. And we who practice the gynae, we know how difficult it is really sometimes to determine, is it really an early invasion or is it still a adenocarcinoma in situ? And even if you consider this is invasion, so depth of invasion in glandular can be really a nightmare sometimes, right? It's very difficult and may not be consensus even amongst the gynecologists. And as you know, when you have a tumor which is confined to the cervix and is certain size, you have, either 1A or 1B. And 1A tumor, usually they are macroscopically, identified, and they are less than 5 millimeter in depth. So the question is, if it is 1A1, what is the management for those, which is usually less than 3 millimeter or 3 millimeter? And if it is between, more than 3 millimeter and less than 5 millimeter, it would be changing the management for the patient. Based on the National Comprehensive Cancer Network guidance, and if you are having a cervical adenocarcinoma with the stage of 1A1. In fact, they may just do follow-up and they may not do anything else like a pelvic lymphadenectomy or sentinel lymph node. Why is it important? Because if you go to 1A, 1-2, you have to offer them pelvic lymphadenectomy. And the reason is because, when we look at the data, we see so many patients underwent lymph node dissection and majority are negative for metastasis. And especially when you look at the morbidity of this, for clinical benefit of this patient, and many of them are very young. Look at this, what you end up if you do a lymphadenectomy of the case of the patient, which may not really need that procedure. So the question was, is there any other pathological parameter that can better identify the patient who are at the high risk of developing lymph node metastasis in cervical adenocarcinoma? So then Silva, who is the gynae pathologist, a very well-known gynae pathologist, and the Anderson and their group, they look at about 350 cases of cervical adenocarcinoma, and all of those were HPV associated. And they have grouped these into three categories, A, B, C. And those were based on a pattern of invasion and how they behave. So when I was a resident, and I'm sure many of you have been always told, what is the criteria for invasion? We always look for presence of single or incomplete malignant glands into the stroma, desmoplastic reaction, lymphovascular invasion, or in this, cervical cancer, we look for the loss of normal lobular configuration, presence of malignant gland beyond the limit of normal glands. So that was always vague and very, I never knew really what is, the line I should say this is beyond the limit. When I was resident, still, when I was practicing. And then the other criteria, which I remember many years ago, again, they used for gland adjacent to thick wall blood vessel. Yes, sometimes it can help, but it's not really a concrete criteria. So the SIPA classification pattern, they use the tumor stromal interface, presence or absence of destructive stromal invasion, LVI, architecture and grade of cytology. So let's look at this on the left side. You can see there is a cartoon, and next to it there is a tissue, which you can see that in pattern A, you don't have any destructive stromal invasion, meaning really there's no desmoplasia. And usually the lobular architecture is preserved, and you do not have any LVI. You may have intraglandular architectural complexity like cribriform or papillary, which I showed you before, which I remember some consultant was just, arguing this is definitely invasive feature, and the other one would say, no, this is still, adenocarcinoma in situ. But in this pattern of invasion, we don't really consider any of these more than pattern A. For pattern B, what you see, you may get some destructive stroma, but it's very limited. When you measure it, surely shouldn't be more than 5 millimeter, or on the microscope should be less than ×4 on your magnification. But you may have LVI. So the thing is, if you have all the feature which is in pattern A and you may have LVI, of course you're going to go to pattern B. Pattern C is relatively easy, and it's like everywhere else. You look at it, it's so extensive desmoplastic reaction. There is distraction, and then when you look at the glands, they are angulated, high NC ratio, and you may have lymphovascular invasion. But what's the importance of this pattern? When they look at their data of their study, they could see there was almost zero lymph node metastasis on the Silva pattern A. They couldn't see any, and there was no recurrences, and any of their patients didn't died of the disease. Whereas when you go to pattern B with limited invasion, in fact, there was an increase in lymph node metastasis, but again, there was none of the cases died of the disease, and the recurrences are very low. Whereas pattern C, obviously, is the higher lymph node metastasis and the recurrence higher, and definitely the many patients died of the disease. So to prevent the procedure of lymphadenectomy, and as a consequence to have a complication, which I showed you a picture of lymphedema. So in fact, if you can correctly put it in category A based on the data of what we have in the Silva classification, then really you are communicating to your clinician, this patient has invasive adenocarcinoma, pattern A, but the chance of having a lymph node metastasis is very low or almost zero. So therefore, they are not going to do any lymphadenectomy. I showed you some of this picture before, and you can see these are still, considered as, when you look at the density of these glands, definitely is much higher than what I expect for adenocarcinoma in situ. I wouldn't feel comfortable to call this one adenocarcinoma in situ. You know what? Maybe if I show it to other colleagues, they may have a different opinion, or myself another day may say, okay, you know what? Maybe still I don't have invasive carcinoma, and I may call it adenocarcinoma in situ. But with pattern classification, we really don't need to be worried about that part. And look at here again. This is, is it really still adenocarcinoma in situ? Most likely. Again, this one. What about this one? When you look at the density, which I mentioned before, it's really, you can see almost most of the stroma is replaced by these glands. I normally don't see so many normal glands in any given, cervical tissue. So definitely you have, the architecture is gone, but you don't have desmoplastic reaction or any invasion into the stromas. Therefore, this is considered as pattern A invasive. What about this one? If you look at the middle lower portion of this slide, what I want to show you is, okay, that area is very crowded and it's abnormal and it is dysplastic. So the question is, in this case, where do you measure your depth of invasion? Because as I said, depth of invasion will determine what is your stage and consequently what would be the next step for the patient. Does this patient needs a lymph node removal? Because here, if you go from the top to the bottom of where is the tumor end, it would be definitely much higher than what you expect for if you measure it differently. But if you give this one as pattern A, let's say, then you are not really implicating to the clinician that they should go and do any lymphadenectomy. So pattern B, again, you see early, this is a cartoon obviously, but early limited destructive stromal invasion. When you look at here, what you see, you have definitely abnormal glandular component. And then in low power, you can see there are some area which looks, the stroma is reacting to. And you go to higher power, you can see there is definitely a small single or small cluster of cell, which they looks different from the adjacent glandular component, and there is a reaction of stroma to this one. And when you measure it, is less than 5 millimeter in linear, or if you go to your microscope, it's definitely less than a ×4 magnification. So this is another example. When you see on the lower portion, this is definitely at least, you have pattern A or adenocarcinoma in situ. And then when you look at on the top area, you can see there is some stromal reaction. Again, the size will determine, is it really still at the earliest, early invasion, or what we call it as pattern B. And pattern C, as I said, is the most easiest one because it's, like every tumor anywhere else, you have a extensive invasion into the stroma with the stromal reaction, and you may have lymph node lymphovascular invasion. And this is an example of that one, which is not difficult at all. Again, for resident, desmoplastic reaction to the tumor, even though the tumor itself looks very rounded, doesn't look really, in most part, not all, it looks infiltrative in a way and angulated, but this is definitely a pattern C. And again, thick blood vessel, yes, it helped, but this one, you don't need really this thick blood vessel to say this is deep enough for invasive. You can see stromal invasion very. What about this one? So when you look at it, sometimes I'm sure you have come across the cases which you look at it and you say, okay, it's mostly exophytic, okay? And when you look at this one, so how do you measure and how do you classify this one? Is it adenocarcinoma in situ? That's very hard to say this is, AIS or adenocarcinoma in situ. Is it invasive? Where does it invade into? So, and how does this patient usually behave, right? These kind of cases. So this is a pattern of viloglandular pattern. And majority of these cases, what you see exophytic growth pattern, and you may get a stromal invasion, which is very limited. Could be, like pattern, in fact, B, which they limited invasion into the stroma. So the question then comes, if you have this one, so what would be the stage for this one? Does this patient needs a lymph node removal? And then obviously as a consequence for the complication of the procedure. And so in fact, if you have a pure, meaning you have no stromal invasion, this would be just, like usual type adenocarcinoma pattern A with viloglandular architecture. That's how we report it. And based on this one, this would be, SIBA pattern based on the stromal invasion, as I mentioned, and usually these follow the same as others based on the pattern of invasion. So you may be, give the depth of invasion from where the tumor invading into the stroma and thickness, both in your report. But really what it should be treated based on pattern of invasion and depth of invasive component, not the size, not the thickness. What about this one? I'm sure if you practice breast or GU, you have seen this kind of pattern, which is micropapillary pattern. And again, this is a usual type HPV associated with the different growth pattern. It's nothing to do with the silver pattern, which I discussed. It's just a different type of growth pattern, which they may have more higher risk of lymphovascular invasion and more aggressive behavior. Again, this is another picture, slide of the micropapillary, like everywhere else, like bladder or breast. So we talk about the usual type, which is HPV associated. I said about 75% of those cases are HPV associated usual type. About 10% of cases you may come across, these are HPV associated, but mucinous subtype. So the mucinous, again, they classified them into 4 category NOS, but the most important is that when you look at this tumor, cells, more than 50% of the tumor cell has got mucin inside, which we call it, NOS, mucinous subtype. If you have more than 50% of your tumor contain intestinal subtype, like the goblet cell, then you call it intestinal subtype. And for signet ring cell, again, more than 50% of tumor should be signet ring morphology. And then, as I said about the SMILE, if you may get a group of invasive adenocarcinoma, in fact, which they have this invasive pattern of growth with stratified mucin carcinoma type, which has got more aggressive behavior. And So if you see it, usually they have a palisading, cell around the big nest of this tumor cell, but the tumor cell has got mucin inside. This is another example of the mucin type invasive one. So that was mostly about the HPV associated. Now let's go to the HPV independent, which is the minority, and those can be actually tricky sometimes. So we have 4 types, which I'm going to just talk about. One is the gastric type, clear cell, endometrioid, and mesonephric. So spectrum of cervical gastric type you may just see pyloric gland metaplasia, which we don't really pay attention to, or type A tunnel cluster or lobular cervical glandular hyperplasia, which can be atypical, or gastric type adenocarcinoma in situ or gastric adenocarcinoma. This is a pyloric type metaplastic changes. This is another tunnel cluster, and then what you see here, hello, what you see here, you can see there are 2 types of this tall columnar cell with a pink, clear cytoplasm, very distinct cell border, and at the periphery, the nuclei are at the base. And when you look at in the left lower portion of this group of glands, you can see the nuclei are a little bit more darker, and you can see there is some pseudostratification. This is, it's retrospective, really. When you look at those in the context of gastric type adenocarcinoma of cervix, which is HPV independent, you may find these, and we consider this as adenocarcinoma in situ of gastric type. And this is another example. What you see, there is a apical mitosis. Occasionally, you may see it, but again, when you look at the nuclei, it's slightly hyperchromatic, and you get different nuclear morphology. This is another one. So, as I said, the most important is just looking at the morphology. If you do HPV testing, P16 as a surrogate marker, when you look at it, obviously it's going to be patchy, meaning it would not be HPV associated. And but when you look at the morphology, you can see this very distinct tall columnar with pink to clear cytoplasm, very distinct cell border, and you may get some apical mitosis. You may not really, you have to really look hard for those features which I'm talking about, apical mitosis or apoptosis. You may not see it at all. But then this is what when you see, you have to be careful about. This is before you even considering this is a gastric type adenocarcinoma, you want to make sure there is no metastasis extension from gastrointestinal into the cervix, because cervical gastric type is so rare, which you have to make sure you rule out a metastasis or direct extension into the cervix before you're making this diagnosis. And again, this is you may have a different spectrum of differentiation in gastric type. This is a well differentiated type, which you may struggle, is it really malignant or not? But then, when you look at this one, for example, you can see definitely there is more nuclear atypia, and there is invasion into the stroma. And again, when you look at the single cell morphology, you see this clears to pinkish cytoplasm with a very distinct cell border. And you have to rule out first, as I said, clinically, there is no gastrointestinal tumor which extend, and then make that diagnosis. But these tumor usually they behave more aggressively than the usual type adenocarcinoma cervix HPV associated. And if you do IHC, again, they can be CK7 positive, PAX8 can be up to 2/3 of the cases can be positive, but if it's negative, again, doesn't rule out that the gastric type adenocarcinoma cervix and ER/PR rarely can be positive. So that's, you need to be aware of this subtype. Clear type adenocarcinoma HPV, it's HPV independent again, and the most important is, in fact, just think about it, and the morphology is similar to what you get in endometrium or ovary. You may have tubular cystic, papillary, solid. Again, you can do immunohistochemistry if you have to, and many of these, in fact, they are, post-exposure to the, in fact, diasteral exposure. And looking at endometrioid subtype, it's very rare. The first thing when you see something like this on the top, slide, you can see this adenocarcinoma. The first thing you think, oh, is this a usual type adenocarcinoma? You do IHC P60 and it's negative. Then you think, okay, it's probably not HPV associated. But then the first thing you want to make sure you are ruling out this is not extension from the endometrium down into the cervix. But when you rule out that part, then you may consider as a primary endometrioid subtype. What it can be, in fact, sometimes can be associated with endometriosis of the cervix. And or if you have confirmatory endometrioid feature, which can be differentiating this one from a usual type adenocarcinoma HPV associated. And this could be considered as a atypical endometriotic, component in the endometriosis of cervix. Again, very difficult. I never really make that diagnosis myself as adenocarcinoma of in situ of endometrioid subtype. So then the next one, HPV independent one, is this tumor. When you look at this one, you say, okay, this is definitely very busy. It looks, has got glandular component. You have some papillary, you have some solid. And so let's say if I have this one, you may think about this is a endometrioid carcinoma, perhaps extending down, could be adenocarcinoma of cervix. You do P16, surely it's going to be patchy positive, meaning HPV independent. And but when you look at under microscope, in higher power, you see this kind of morphology, what is overlapping with clearing of the chromatin and some grooves. So when you have this morphology, one thing you have to think about is the mesonephric subtype. And those tumor usually more aggressive tumor again, the same as what you may get mesonephric in endometrium or mesonephric-like endometrial adenocarcinoma. And again, the precursor of this lesion, we don't really know exactly what could be, but mesonephric remnant in the cervix can be considered, as they go under obviously some alteration and then develop into the mesonephric adenocarcinoma. So eventually, what I want to convey is when you have a report, you want to just make sure you're going to use the classification of HPV associated or HPV independent. You want to include your pattern of invasion, Silva pattern, and clearly convey that one to your clinician, which is now, as I said, from 2020, is part of WHO. I don't know if there is any other place still they don't use it or clinicians are not aware. But then again, we want to give the tumor size, depth of invasion, and horizontal extent has been really removed for the purpose, and we don't use that one for staging anymore. And lymphovascular invasion, if it's present or absent, and obviously you want to give if there is any margin status either for in situ or invasive carcinoma. And then this, at least this has to be included in your report. And with that one, I want to just thank you and say that, IECC 2018 and silver classification are definitely, we know it's incorporated into W2020, and it's going to carry on for 2026. And both of these can be assessed on H&E, and they would be helpful in the management decision making for the patient, for our clinician. And thank you very much. And if there is any question, I would be happy to answer.
Thank you very much. That wonderful talk. As I said, I had another talk to go to in the middle, so I didn't catch all of it. Had a really good explanation, particularly bringing it all together there with a conclusion about to put it all together. Are there any questions from the audience, please? There must be some. Okay, Apana says thank you very much, and Joanne says thank you very much. Are there any questions from the audience?
Can I ask the attendee, in fact, is there any center which they still not use silver classification and they don't include it in their report?
Okay, so is there anyone not using the silver classification and not using it in their report? If anyone could just say, we're just interested to know how widely it's being used, or maybe people, if people reply who are using it, that might be easier.
I expect majority of center, hopefully they use it, but again, we don't really. I don't have.
So, okay, so in Egypt, Engi says the clinicians are not familiar with it, so they always need to explain it. So, Engi, you're using it, but you have to explain it each time. Is that correct?
It's all depends. It's one of our job is really to communicate that one with our clinician and sometimes to educate them really if they are not aware of it. And that would be in MDT usually. That is when I remember before 2020 WHO came out, we were using this one in our center, and we always discuss it with our clinician till the time when if someone didn't use it, they would request it. They get used to it and they knew what they want to. Yeah.
And is anyone else in the same situation as Engi having to explain it to their clinicians? In India, also, only some institutes use the silver classification. Okay, so this talk has been really useful, Hamid, in broadening the scope of this classification. So, has anyone, does anyone think that they might change their practice as a result of this talk, or at least consider changing their practice with their clinicians if they don't already use the silver classification?
As I said, definitely there are cases which the patient doesn't really need a lymphadenectomy or sentinel lymph node. If we have a pattern A, and plus it would be much easier really to say, okay, this is a pattern A and not struggling. Is it really invasive or non-invasive? And especially if we have to give the depth of invasion, as I just show, and I'm sure the audience knows, that it's very difficult sometimes to say really where should we start to measuring, right, for the depth of invasion. We don't want to overcall and
absolutely
overtreat our patient.
Yeah. So the silver classification kind of avoids overtreatment.
Yeah, it would hopefully stop the overtreatment or undertreatment. Overtreatment for sure. Yes.
Are there any more questions from the audience? Okay, so basically we get a lot of doubts, so Gopinder Threddy says basically while reporting we get a lot of doubts in depth of evasion. So do you mean, Gopinder Threddy, that you have difficulty measuring the depth yourself, or people or the clinicians question your depth? Yeah, difficulty measuring the depth. Okay.
That is, you're not alone. That is a difficult area. We know that, and we struggle. Sometimes I have to go to my colleagues or sit together in a group and just show where we are measuring, especially when it's something is going to change the staging and, as I said, the implication for the patient. And that can be sometimes difficult, surely, and you have to use your best judgment. But this will help. At least what I was trying to convey is the Silva classification would be helpful for. Imagine if you have a pattern A and you are measuring from wherever to wherever, right? And in fact, really doesn't matter, because if pattern A, they shouldn't really do any further procedure, because these patients usually they behave well. They don't need any lymphadenectomy. They need just to be follow up.
Mariama asks, how do you measure depth and thickness for invasive adenocarcinoma?
How do I measure? So it depends, if you have like an exophytic tumor, which I was showing some viloglandular one. So definitely you just give, whatever from the top to, to the wherever is the bottom of your proliferation or glandular, proliferation is as a thickness of your tumor. But if you are dealing with, it's not like squamous. We are, we are dealing here with the adeno, and that is from the surface where you have it, right? Where you think it is, the tumor is rising from, to the deepest portion of wherever this tumor invading into.
Okay. Are there any more questions from the audience? And are people able to put in the chat, please, the locations of the world where they're joining from? It's always nice to have that feedback for the speaker in particular. India. Thank you. Chile. Anyone from UK, Tanzania? More from Chile?
Again, yeah. I would just, sorry, I would just add, if you're using digital pathology, that give you a little bit better, easier way to measure because of, the tools rather than the microscope. I don't use microscope anymore for a few years now. Yeah, it just gives me so much, easier to just measure.
So it's easier with digital pathology. And do you think there's a role for AI solutions in measuring things like that?
I found it difficult. Again, it depends what we, how we train the AI. If we are not still, certain exactly where we should and we use our judgment, I found it difficult for now.
Okay, well thank you very much. I know everyone's very busy. Thank you very much for your time, Hamid. We've also got people joining from Chile, Canada, and Nicaragua. Hamid, I look forward to seeing you in Oxford later in the year.
Absolutely.
At the Symposium. I may not make the full histology symposium, but I'll certainly be there for the AI components of that symposium. So I hope you're there.
Absolutely, yes. Looking forward to see you. Thank you very much again for giving me the opportunity.
Thank you very much to
Thank
Charlie.
You. Thank you very much, everyone, and have a lovely night. Yeah.
Thank you, Hamid.
And
Thank you.
Charlie, just to let the audience know, tomorrow, next week, it'll be Dr. Sidra Jahinga talking on inflammatory bowel disease and dysplasia. Same time next week, Dr. Sidra Jahinga on inflammatory bowel disease. So please share the link and with all your colleagues. So look forward to seeing you all again next week. And in the meantime, good morning, good afternoon, good evening, and good night. Thank you very much.
Thank you, Bob. Have a good day.
Bye. Bye.